डन अभी लाइव इसमें आएगा ना. All right. Hello students, good afternoon. Yeah, good afternoon everyone. Am I visible and audible? Am I visible and audible? All right. So let's not waste any time. Our aim is that we try to cover as many questions as possible, as many topics as possible that are likely to be asked in the examination. 20th का जो एग्जाम है उसके लिए. So जल्दी से करते हैं. Let's try to cover. Let's hope that we get all the questions right. ये क्या लैग कर रहा है क्या? चलिए. All right, let's start. Now this is an important question. ये एग्जाम में आता है. Please remember that this is often asked in the examination. MSc mental status examination. Basically एग्जाम में क्वेश्चन क्या आएगा? What is the question that they are going to ask? They'll say the clinical examination in psychiatry. What is it called? Clinical examination in psychiatry. What is it called? The answer is MSc. Usually the options they give is clinical examination in psychiatry is called as MSc, PSc, DSc, BSc. Our answer is going to be mental status examination, right? क्यों हंस रहे हैं लोग? क्या हुआ? अच्छा यार हमारे ये इसमें भी जा रहा है ना? अच्छा ठीक है. ठीक है. So let's talk about the components of MSc. What all are the components of MSc? The first one that we need to know is perception. Now there are two things that you have to remember: illusions and hallucinations, right? माइक थोड़ा ऊपर लगा लीजिए. All right. What is illusion? False perception false perception of a real object. Right? There is something, but you are perceiving it falsely. For example, instead of a rope, you saw a snake. This is an illusion. एग्जाम में क्वेश्चन कैसे आता है? A patient is walking, he mistakes a rope for a snake. What is it called as? It is an illusion. Hallucination is false perception without any object. There is nothing, but you still saw something. There is no rope, there is nothing, but you still saw a snake. That becomes a hallucination. Now in our last year FMGE examination, a question was asked from this topic, from the topic of hallucination, especially the properties of hallucination, right? So let's talk about it. Last year question है अपना, what are the properties of hallucination? So the first property that I said, पहली बात जो मैंने बोली, that was hallucinations occur in the absence of any stimulus. There is no stimulus, but still you are seeing something or you are hearing something. Second is hallucinations are as clear as a real perception. जो reality होती है, the real perceptions are very clear, right? For example, you are watching me on your phone screen or your laptop screen. You can watch me very clearly. You can see me very clearly. Everything is clear. Similarly, when a person has hallucination, the hallucination is so clear that the person cannot differentiate between reality and the hallucination. Hallucinations occur in outer and objective space. What is the meaning of outer and objective space? Outside my body. Say a person comes to me, he says he hears some voice, and I suspect that he is having auditory hallucinations. I ask the patient, from where do those voices come? The patient says the voices come from outside. Another patient comes and says, doctor, the voices come from within my mind. मेरे ही मन की आवाज है. The voices come from within my mind. So the patient who is saying the voices come from outside, for that patient, we can say that the third criteria is fulfilled, that voices are coming from outside. If somebody says voices are coming from within my mind, उसको हम बोलते हैं inner and subjective space. अंदर से मन की आवाज. And the fourth is hallucinations are not under the willful control. You cannot control the hallucinations. So the question that was asked in FMG examination basically talked about pseudo hallucination. So for a perception to be hallucination, A, B, C, D, all four criteria must be fulfilled. ठीक है? If the criteria A is fulfilled, if the criteria B is fulfilled, but the criteria C is not fulfilled and the criteria D is fulfilled, which means rather than occurring in outer and objective space, if it is occurring in inner and subjective space, then it's called a pseudo hallucination. ठीक है? याद आ गया? This is an important thing. It was asked in the examination. Alright, आगे बढ़ते हैं. Delusion. Delusion is a false belief. There is a belief which is false. And you try to break that belief by giving evidences. You try to give evidences to break that belief. But the patient still continues to hold that belief and his belief is not explained by the background. Right? False belief does not break, not according to the background. We call it delusion. Common question in FMG examination. Delusion is a disorder of which part of thought? Is it a disorder of flow of thought, form of thought, content of thought? Batao. Very good. Mutib, very good. It's a disorder of content of thought. Excellent said. Very good. बहुत बढ़िया. Pandey ji, very good. Content of thought. Delusion is a disorder of content of thought. Has been asked multiple times. Types of delusion. Common question, important question. There are many types. We'll focus on those which are asked in the exams. The first is delusion of persecution. Persecution matlab somebody is trying to harm me. Patient may come and say, my neighbors want to kill me. My family members want to take away my property. The police is following me. The CBI is following me. Right? There may be multiple examples, but basic theme क्या है? कि लोग मुझे harm कर रहे हैं. People are trying to harm me. This is delusion of persecution. Delusion of love, also called as de-Clermont syndrome. Patient believes that somebody is in love with them. Patient को लगता है somebody is in love with them. That alleged lover might not have ever even talked to this person, the patient, but still the patient thinks somebody is in love with me. Delusion of infidelity, also called as morbid jealousy, pathological jealousy, or Othello syndrome. What is it? Partner is cheating. Partner is cheating. Patient thinks that the partner is cheating. My wife is cheating. My husband is cheating. My girlfriend is cheating. My boyfriend is cheating. Partner is cheating on me. Right? Morbid jealousy can be seen in patients who have alcohol dependence. It can be seen in patients who have psychotic disorders, also in alcohol dependence. Important point. Nihilistic delusions. Exam question. Not FMG में नहीं आया था, but it was asked in NEET PG examination. Might be asked in your exam also. Nihilistic delusion. Nihilism. Nil. Nihilism क्या होता है? Nil. Nil मतलब end. Patient thinks everything is ended. सब कुछ खत्म हो गया. Patient may come and say, my internal organs are rotten. Organs are rotten. Or everybody in the world is dead. Or the water has frozen. Basically, everything is to do with the end. सब कुछ खत्म हो रहा है. This is nihilistic delusion seen in Cotard syndrome. There's a syndrome called Cotard syndrome in which nihilistic delusions are there usually along with severe depression. Right. सब कुछ खत्म हो गया. Aditya, difference between Cotard and nihilistic is Cotard is the name of syndrome in which we see nihilistic delusion usually with severe depression symptom. Right? Syndrome है, ये एक symptom है. अब एग्जाम के हिसाब से ये इंपॉर्टेंट है. Delusion of misidentification. Delusion of misidentification. Right? Misidentification. Patient को लगता है और patient has false belief regarding the identity of people. There are two important syndromes, Capgras syndrome and Frigoli syndrome. In Capgras syndrome, इसको हम ऐसे याद करेंगे, Capgras syndrome, close person got replaced by a stranger. For example, patient thinks wife got replaced by a similar looking stranger. Wife got replaced by a similar looking stranger. Patient will enter his house, will go to his drawing room. In the drawing room, wife is sitting, but patient will get a thought, or patient has a belief that this woman sitting in my drawing room who looks exactly like my wife is not my wife, but a double. She is a double. She is a duplicate. She is a stranger, and he will start fighting with the wife. So Capgras patient fights with a close person, accusing them of being a stranger. ठीक है, याद रहेगा, इसको याद रखना. क्लोज, देखो CPGRAS, Capgras, close person got replaced by a stranger. एक याद रख लो, the other one is the other one. ठीक है. अब आपके एग्जाम में क्वेश्चन आया था लास्ट ईयर, इन विच डिमेंशिया Capgras syndrome is most commonly seen. So it is most commonly seen in Lewy body dementia. Lewy body dementia. It can also be seen in Alzheimer's, but more commonly seen in Lewy body dementia. ठीक है. Frigoli syndrome में उल्टा होगा. Patient will think that a familiar person is giving you a गोली. गोली बोलते हैं ना, बेवकूफ बनाना, trying to make a fool out of you. Here the patient thinks that wife has changed her appearance to look like a stranger. वहां पे the patient was thinking a stranger has replaced wife. यहाँ पे patient is thinking wife is deliberately changing her appearance and looking like a stranger, right? A familiar person is changing the appearance and disguising as a stranger. ठीक है, से बहुत हीट हो रही ना. Wife has changed her appearance to look like a stranger. Just a second. हाँ, उसको इसे चला दो गरम गरम सा. खुद डाल दूं क्या? मैंने अंदर दो भी पहन रखी हैं. हाँ सॉरी गाइस, ठीक है, हो गया, ठीक है, याद रहेगा. नाउ लेट्स टॉक अबाउट इंसाइट. व्हाट इज इंसाइट? अवेयरनेस ऑफ द इलनेस. इंपॉर्टेंट क्वेश्चन एग्जाम में बार बार आता है. इफ आई एम इल and I know that I am ill, my insight is present. If I am ill and I don't even realize that I am ill, my insight is absent. याद रखेंगे इसको, इंपॉर्टेंट थिंग है. 5 ग्रेड्स जो होते हैं इनसाइट के, दे आर रेयरली आस्क्ड इन आवर एफएमजी एग्जामिनेशन. सो लेट्स फोकस ऑन द डेफिनेशन. राइट नाउ लेट्स टॉक अबाउट द इंपॉर्टेंट टॉपिक schizophrenia and the mood disorders. Now in the last 4-5 years, if you see, from schizophrenia and mood disorder, almost every single question is coming from the treatment part, right? So we'll focus on the treatment part. We'll cover the treatment in more detail, I mean complete details, and not focus on things that are never asked in the exams in the last 5 years. So what is the treatment of schizophrenia? The diagnosis of schizophrenia you would be able to make. You will be given history of delusions. You will be giving history of hallucinations primarily, and according to ICD, if the symptoms are for more than 1 month, you can make the diagnosis. And according to DSM, if the symptoms are for more than 6 months, you can make the diagnosis. ठीक है, diagnosis बनाने में it would not be much difficulty. Usually history of delusions and auditory hallucinations is given, right? But the problem comes in treatment part. So treatment may we use antipsychotics. The questions usually come from 2 areas. First of all, they will ask about the side effects of antipsychotics, and secondly, they will ask question from a particular drug, clozapine. So let's first talk about the side effects. And before that, antipsychotics are of 2 types: typical antipsychotics and atypical antipsychotics. First generation and second generation. First generation usually works by D2 antagonism. They block D2 receptors. Atypical block D2 receptors and 5-HT2A antagonist. They are effective against only positive symptoms. They are effective against positive as well as negative symptoms. The D2 blockade treats positive symptoms. The 5-HT2A blockade treats negative symptoms. Because your typical antipsychotics are not working on 5-HT2A, they are effective only against the positive symptoms. Extrapyramidal side effects, जो we'll study after this slide, they are more with typical antipsychotics and they are less with atypical antipsychotics. But metabolic side effects like weight gain, like dyslipidemia, like increased blood sugar levels, diabetes, they are less with typical and more with atypical. ठीक है? Alright, let's talk about the important side effects. So, extrapyramidal side effects, the name that we give to the entire group of these side effects is extrapyramidal side effect. The first one is drug-induced Parkinsonism. Parkinson's में क्या होता है? In Parkinson's we have less dopamine, right? We have less dopamine in basal ganglia. When you give antipsychotic, the same thing you are doing. You are blocking the dopamine receptors. Effectively, there is less dopamine in basal ganglia. So patient starts developing symptoms of Parkinsonism. The triad: tremors, rigidity, bradykinesia. What is the treatment? Anticholinergics. You can use them prophylactically. If you are giving a typical antipsychotic, give prophylactically anticholinergics. If the patient develops Parkinsonism drug induced, you give anticholinergics, right? Benztropine, trihexyphenidyl, promethazine can also be used sometimes. All this can be given. Acute dystonia, your possible image-based question. You give patient a medication, probably intramuscular injection, immediately the eyes roll upwards. Dystonia. Earlier side effect, what is it? Sudden contraction of a muscle group. If your sternocleidomastoid gets contracted, it will cause torticollis. If your extraocular muscles get contracted, it is causing oculogyric crisis. If your jaw muscles get contracted, it will cause trismus. Treatment क्या है? Same. You give anticholinergics. But if the patient comes to you with uprolled eyeballs, you have to give intramuscular anticholinergic. Like IM promethazine दे देते हैं, intramuscular anticholinergic दे देते हैं, like promethazine. Similarly, आप prophylaxis में भी you also give the anticholinergics, right? Important question, याद रखना है. Patient given antipsychotics, sudden uprolling of eyeballs, sudden torticollis, treat with intramuscular anticholinergics. Akathisia, most common side effect. Patient says two things. Patient says that I feel restless and I cannot sit on the chair. I cannot sit on the table. I cannot sit on the bed. I keep walking around in the house. So patient subjectively says that there is restlessness. And objectively when you see the patient, patient is fidgeting. Patient is not standing. Patient कभी एक पैर पे दूसरे पैर पे, one leg, second leg, right? Keeps on fidgeting, keeps on roaming around. So subjective feeling and objective signs. What is the treatment of akathisia? कौन बताएगा? What is the treatment of akathisia? Dr. Smile, propranolol, very good. Pande's propranolol. Brij Bhan Singh Yadav ने क्या बोला? बीबी क्या होता है भाई? बीटा ब्लॉकर, ओके. Silva Murthy, propranolol, very good. Very good, right? Propranolol. चलिए. Tardive dyskinesia. What is the meaning of tardive? Tardive is long term. When you give antipsychotics for a long period of time, patient develops certain side effects, movement side effects. Dyskinesia is abnormal movement. Tardive is long term, right? Patient may develop movements of jaw, like chewing movement. It appears as if patient is chewing movement, yeah, smacking, things like this, puckering, right? All of this may be seen, or there may be movement of hands, extremities, or rabbit syndrome, right? The patient keeps on moving the lower, keeps on moving the jaw like in a rabbit-like movement. This is all tardive dyskinesia. How do you treat? Shift from the first generation antipsychotic to second generation antipsychotic, because all these extrapyramidal side effects are less common with second generation. And if you're asked the drug of choice, you can use dopamine depleters like valbenazine and tetrabenazine. Which is the lethal side effect of antipsychotics? NMS, neuroleptic malignant syndrome. NMS is the lethal side effect. याद रखना है, lethal side effect. There are multiple symptoms. For your exam purposes, 99% of the questions can be solved if you remember fever, rigidity, and increased CPK levels. Fever, rigidity, increased creatinine phosphokinase levels. If you remember these three, 99% of the times you would be able to answer the question. And what is the drug of choice for NMS? Very good. The drug of choice for NMS is dantrolene. Drug of choice for NMS is dantrolene. Very good. Apart from the movement side effects, the extrapyramidal side effects, the patient can also develop endocrine side effects. Why? We know that the release of prolactin is inhibited by dopamine. Dopamine inhibits the release of prolactin. When you give dopamine antagonist, dopamine cannot inhibit the release of prolactin. What will it lead to? Hyperprolactinemia. And when hyperprolactinemia happens, in females there is development of galactorrhea and menstrual disturbances and sexual dysfunction. Similarly, men will also develop sexual dysfunction, right? Low libido, definitely. This is about endocrine side effects. Clozapine. Now, clozapine is a very important antipsychotic because it is a drug of choice for TRS. TRS क्या होता है? It is treatment resistant schizophrenia. Basically, lack of response to two different antipsychotics. usually out of which one is an atypical antipsychotic. Patient does not respond to two different antipsychotic. You gave first antipsychotic, did not improve. You gave second antipsychotic, still did not improve. And out of these two, one is an atypical antipsychotic. In this case, drug of choice is clozapine. So clozapine is a great drug, but you do not give it in usual circumstances to the patient. You give it only for TRS patient. Why? Because of the side effects. There can be significant side effects of clozapine. What are the side effects of clozapine? There are three life-threatening side effects of clozapine. The first one is agranulocytosis. The second one is myocarditis. And the third one is seizures. Because clozapine can cause agranulocytosis, that is why when you give clozapine, you always do ANC and TLC monitoring. ANC or TLC monitoring आप करते हैं. What is the most common side effect of clozapine? Sedation. What is the most important side effect for exams? Cyalorrhea. Patient has excessive salivation. Excessive salivation. ठीक है? Very good. If you are given history of a patient in catatonia मतलब patient presents to you with posturing. Posturing क्या होती है? Maintenance of a posture for a long period of time. Patient is presenting to you with posturing, or he is presenting to you in stupor. Or FMGE examination question, echolalia. What is echolalia? Echolalia क्या होता है? Repetition of speech. FMGE question, repetition of speech. Or patient presents to you in echopraxia. Echopraxia क्या होता है? Repetition of behavior. All of this is telling us that the diagnosis is catatonia. The first line treatment of catatonia is intravenous lorazepam and electroconvulsive therapy. And if you have to choose, you always choose IV lorazepam first. Intravenous lorazepam and electroconvulsive therapy. Of course, you don't want to give ECT directly, so you give lorazepam first. Alright. Prognosis in schizophrenia, important topic. Good factors, bad factors. If the onset is acute, if the symptoms started suddenly, they would also go away. If symptoms came very slowly, they would not even go away. Good prognosis, acute onset. Bad prognosis, insidious onset. Late age onset is better prognosis. Early onset is bad prognosis. Females, better prognosis. Males, bad prognosis. Too many positive symptom, good prognosis. A lot of negative symptom, bad prognosis. Right? No SID, ECT is not illegal. Now the law has banned direct ECT, but indirect ECT is allowed and it's a good treatment method. We'll talk about it in the last slide. Patient is having schizophrenia and is also having depressive symptoms. Better prognosis. Patient is having schizophrenia, does not have any emotions. Affective flattening is there. Bad prognosis. Family history of schizophrenia, bad prognosis. Family history of mood disorder, better prognosis. ठीक है? Right? याद रहेगा? Very good. चलो, let's talk about the depressive disorders now. See, you don't really have to remember the symptoms the entire list of symptoms need not be remembered. You can easily make the diagnosis. Depression में क्या होगा? What is going to happen in depression? There would be sadness of mood, lack of interest, negative thoughts, usually decreased sleep, decreased appetite. There may be suicidal thoughts, right? All these symptoms would be there and they have to be there for at least 2 weeks. before you can make a diagnosis of depression, right? So the diagnosis of depression you can easily make just by looking at the symptoms. You can easily make, right? These are the symptoms. What is the hypothesis behind depression? We are still stuck at the level of hypothesis. We say that low levels of serotonin, low levels of norepinephrine, and low levels of dopamine. The three monoamines are responsible for development of depression. Out of these, the most importance is given to serotonin. This is the biological theory, or in biological also, to be precise, monoamine hypothesis. There is a psychological theory also called as cognitive theory. It says automatic negative thoughts cause depression or maintain depression. It says that patient keeps on getting negative thoughts in mind, because of which they develop and maintain depressive symptom. Out of many negative thoughts, there are three thoughts which are most important, and these thoughts are called Beck's cognitive triad. What are these three thoughts? Negative view of self, ideas of worthlessness, bad thoughts about yourself. I am not good, I have no qualities, I have no worth. Negative view of the environment, that the world is a hostile place, I am helpless. And negative view of future, that the today is bad and even the tomorrow is going to be bad. Ideas of hopelessness, right? Ideas of hopelessness, helplessness, and worthlessness. Out of these three, the most dangerous is ideas of hopelessness, because it increases the suicide risk. If somebody loses hope that nothing is going to improve in my life, then the chances of attempting suicide go up. ठीक है? Getting everything? चलो. Treatment. Treatment में we use pharmacotherapy and we use psychotherapy, right? Usually the first line treatment for depression as far as medications are concerned is they are SSRIs. Why? Because of their better side effect profile. And what is the psychotherapy of choice? Cognitive behavioral therapy. We said in depression people get negative thoughts. Managing those negative thoughts is what you do in cognitive behavioral therapy, right? So let's talk about the antidepressants first. So the first class is tricyclic and tetracyclic antidepressants, which block the reuptake of both serotonin and norepinephrine and increase the levels of both serotonin and norepinephrine. Nowadays they are not really used routinely, but they are very important as far as exams are concerned. Why are they not used routinely nowadays? They are good medications, but they cause a lot of side effects. They cause a lot of side effects because they block your muscarinic receptors. If any medication, if any drug blocks muscarinic receptors, it would cause a lot of anticholinergic side effects like constipation, urinary retention, dry mouth, blurred vision, sweating decreases, even delirium. Because TCAs can cause anticholinergic side effects, that is why you don't give them in benign prostatic hyperplasia. Benign prostatic hyperplasia you don't give. Patient already has BPH, you give anticholinergics, patient may go into urinary retention. Similarly, patient has glaucoma, angle closure glaucoma, you give TCAs, patient may have an acute attack. Okay? So because of this, you do not give TCAs in patients who have BPH or who have angle closure glaucoma. याद रहेगा ये? Apart from blocking the muscarinic receptors, these drugs also block the adrenergic receptors. If you block the adrenergic receptors, BP will fall. BP will fall. There would be tachycardia. Also, these drugs also block sodium channels. And if you block the cardiac sodium channels, arrhythmias will develop. So, blockade of alpha adrenergic receptors and cardiac sodium channels. BP is falling, QT is getting prolonged, arrhythmias may happen. ठीक है? Now this is important. Commonly asked question. The therapeutic index of TCS is very narrow. The dose at which they become toxic and the dose at which they are effective, there is not much difference. So we said that TCS have anticholinergic effects, anti-adrenergic, alpha-adrenergic effect and sodium channel blockade. If somebody takes an overdosage of TCA, what will happen? In CVS, BP will fall. There will be tachycardia. There might be chest pain. CNS, the sensorium gets altered. There may be respiratory depression and convulsions. Autonomic nervous system, all of your anticholinergic side effects. And because of CVS and CNS impact, there is development of tissue hypoxia leading to metabolic acidosis. Why is it important? We'll see in the next slide. ECG findings, सबसे important, most important is the QRS interval gets prolonged. The QRS interval gets prolonged. Now, if you are given history of a patient with TCS toxicity and if the QRS interval crosses 100 milliseconds, the treatment of choice is sodium bicarbonate. Remember, there was metabolic acidosis. You correct the metabolic acidosis by giving sodium bicarbonate. याद रखना है इसको. कई बार they would not give exactly more than 100 milliseconds in the exam. Still, you have to remember that you have to use sodium bicarbonate if QRS interval is prolonged. And if you get to know that somebody has overdosed on TCS, you can use gastric lavage to take out the unabsorbed pills. ठीक है जी, समझ आ रहा है? याद रहेगा? वेरी इंपॉर्टेंट क्वेश्चन, बहुत बार आता है. इट्स अ वेरी इंपॉर्टेंट क्वेश्चन, भूलना नहीं है इसको. टीसीए टॉक्सिसिटी का क्वेश्चन गलत करके घर नहीं आना है, याद रखना है इस बात को. SSRIs, how do they work? They block the reuptake of serotonin, right? All of these are your SSRIs. Side effects are asked in the exams. Short term में most common side effect nausea, vomiting. Long term में most common side effect sexual side effect, right? Most commonly long term side effect is libido goes down, delaying of orgasm may happen, even there might be disturbances in erection. ठीक है? SNRIs, एग्जाम में क्वेश्चन आया था वेनलाफेक्सिन के ऊपर. दे आस्क्ड अ क्वेश्चन ऑन वेनलाफेक्सिन. व्हिच ऑफ द फॉलोइंग ड्रग इज अ SNRI? रिमेंबर FMGE PYQ. Answer was venlafaxine. Blocks the reuptake of both serotonin and norepinephrine. Sometimes we say that SNRIs are better in severe depression. Some studies say that, not all studies. Side effect profile is quite similar to SSRIs. But there is also hypertension. Why hypertension? Serotonin, norepinephrine reuptake is getting blocked. Levels of norepinephrine go up. If norepinephrine goes up, hypertension will result, of course. Alright, then we say psychotherapy. The best psychotherapy, that the therapy with most evidence is cognitive behavioral therapy. FMG PYQ. If a patient presents to you with mild depression, both CBT and medications can be used. They are equally effective, right? So if they give you a history of a patient who has mild depression and either she is pregnant or she is lactating, and then they ask you what is the best treatment method. Now if a person is pregnant or if she is lactating, you do not want the medication to go into the child, and you know that in mild depression CBT or SSRI is equally effective. They are equally effective. So you choose CBT. You choose CBT, right? FMG PYQ है. देखा था, you remember that, right? FMG PYQ. Lastly, ECT. if they give you history of a patient who has depression with high suicide risk, matlab the patient has made a recent suicide attempt or is having a lot of suicidal thoughts. If you think that the patient has high suicide risk, then the treatment of choice is electroconvulsive therapy. If your patient has high suicide risk, they ask you what is the best treatment here. What you do is you offer the patient electroconvulsive therapy. Pandey ji पूछ रहे हैं in parasuicide? No, Pandey ji, in parasuicide we usually do not offer ECT. What is parasuicide? Basically the person harms self but no intention to die. Say, if you are cutting yourself superficially, you know that you are harming yourself, but you know that you would not die of it. So you harm yourself, but there is no intention of death. चले आगे. FMG क्वेश्चन, डिस्थाइमिया एंड डबल डिप्रेशन. हाँ जी. हाँ अभी नहीं, अभी तो मैं रहूँगा यहीं पे. आप इवनिंग में छोड़ने का मुझे कॉल करिएगा. माइल्ड डिप्रेसिव सिम्टम्स continuing for more than 2 years. Mild depressive symptoms continuing for more than 2 years is dysthymia. Mild depressive symptoms continuing for more than 2 years is dysthymia. ठीक है. What is double depression? Say a patient has dysthymia and now develops depression. So dysthymia was continuing for say 5 years and now patient has also developed depression. Now this is called as double depression. Your FMGE examination PYQ. Got it? Alright. Let's talk about mood disorders. So we have got bipolar 1, bipolar 2. In bipolar 1 we have episodes of mania plus depression. In bipolar 2 we do not have episodes of mania, we have hypomania plus depression. So there is no mania in clinical examination of double depression. Khushi is asking. So say somebody, a teacher was having some symptoms for 3 years. He would feel sad, he would occasionally have sleep disturbances, he would not enjoy life much, but he was continuing to go to the office. And suddenly for the last 3 months, symptoms worsened. Now he's crying the entire day, has lost the sleep, has lost the appetite, is having a lot of suicidal thoughts. So this is double depression. Already it was going on, then it increased. So symptoms of mania, again, what will happen? The mood is elevated. Patient is euphoric. What is euphoria? Excessive happiness without any reason, right? Activity levels are increased. Need for sleep is less. There's flight of ideas, right? All of this is your mania symptoms, right? Patient is speaking a lot, patient is looking very happy, patient is doing a lot of activities, not sleeping, right? Making big plans, having grandiose ideas, thinking that I am very powerful, thinking I am very rich, like all those things. The question usually comes on the treatment part. So, but what is the difference between mania and hypomania? All these symptoms continuing for more than 7 days. Hypomania, what is this? Less severe symptoms are same, but they are less severe. Similar symptoms but less severe, and the duration criteria is 4 days. And they also cause less impairment in life. Same symptoms, less severity, less impairment, and 4 days duration criteria. Treatment of bipolar disorder. If a patient comes to you in acute episode, acute manic episode, you use primarily 2 type of drugs. You use mood stabilizers. The 3 main mood stabilizers are lithium, valproate, and carbamazepine, and you use antipsychotics, usually atypical. If a combination is in the option, mood stabilizer plus antipsychotics, preferred answer. If they give you history of a patient with mania and they ask you the treatment, better answer is you give a combination of mood stabilizer and antipsychotics. If in the question this option is not given, agar combination is not in the options, then you prefer antipsychotics over mood stabilizer. Question comes in the exam, a patient presents to you, is speaking a lot, sleeping very less, making big claims, fighting with everybody, over talkative. What is the best treatment? Option 1 lithium, option 2 valproate, option 3 risperidone, option 4 lorazepam. You prefer risperidone. ठीक है? Antipsychotics will be preferred over the mood stabilizer. Lithium, important drug, important question. Your body handles lithium the way it handles sodium. Why is it important? In any situation where the reabsorption of sodium increases, the resorption of sodium increases, the reabsorption of lithium also increases in the kidney. The only way the lithium can be excreted from the body is through kidney. And if the excretion through kidney slows down or decreases, it may cause what? Lithium toxicity. Anything that increases the reabsorption of sodium will increase the reabsorption of lithium and can cause lithium toxicity. अब इसको देखते हैं. What are the levels of lithium that are effective in acute mania? So the latest edition of synopsis say for acute mania the lithium levels should be 1 to 1.2 milliequivalent per liter. And for prophylaxis, lesser levels are required, 0.4 to 0.8 milliequivalents per liter. Toxicity is usually seen in more than 1.5, and this is something that you need to remember. If you want to see the serum lithium levels, you tell the patient that take the drug at night. Say the patient take the lithium tablets at 10 o'clock in the night. After 12 hours, which means at around 10 a.m. in the morning, without taking the morning pill, without taking the morning lithium pill, the blood sample is to be given. So blood sample is taken 12 hours after the last dosage. You basically want to catch the trough levels. Okay. Rather than giving 1 to 1.2 or 0.4 to 0.8, they may also give 0.6 to 1.5 milliequivalent per liter also in the exam. This was earlier the books used to say 0.6 to 1.5 is the effective dose. So इसको याद रखना, 0.6 to 1.5 is the effective dose. राकेश, लास्ट स्लाइड में मैंने टॉक्सिसिटी की बात की थी, वो मैं नेक्स्ट स्लाइड में वैसे भी करूंगा. What are the side effects of lithium? First is tremors. Postural tremors may happen. Right? This is important. ये सब भूल जाओ. Postural tremors may happen. Hypothyroidism may happen. Importantly, postural tremors, hypothyroidism. Polyuria followed by polydipsia. Postural tremors, hypothyroidism, polyuria and polydipsia. And the important one, teratogenic side effect is abstinence anomaly. During pregnancy, if the mother takes lithium, it can cause abstinence anomaly. Right? Lithium toxicity. Anything that increases the reabsorption of sodium will increase the reabsorption of lithium. For example, diet. Patient starts fasting. Patient is fasting. The fluid intake decreases. The body tries to save all the fluid. The body tries to save all the fluid. The body tries to save all the fluid. To do that, the body will reabsorb a lot of sodium. And while reabsorbing a lot of sodium, the body will also reabsorb a lot of lithium. Right? Diuretics, you know that one of the side effects of diuretics is hyponatremia. If there is hyponatremia, body tries to reabsorb the remaining sodium. It ends up reabsorbing the lithium also. Diarrhea, there is hypovolemia. Again, body tries to reabsorb sodium. It ends up reabsorbing the lithium also. So in all these conditions, there is chances of lithium toxicity. There are chances of lithium toxicity. So what you must remember is, whenever they want to give you a question on lithium toxicity, what will they do? They will give history of a patient of bipolar disorder on lithium, either starts fasting or has diarrhea, vomiting, and then he develops abdominal symptoms plus CNS symptoms, and you are asked the diagnosis. A patient who has bipolar disorder for last 5 years was maintaining well, suddenly started fasting for religious reasons. Now he presents to you with abdominal pain and vomiting, and you see that the patient is having tremors, difficulty in walking and difficulty in speaking. What is the likely diagnosis? Lithium toxicity. Tremors, ataxia, dysarthria, and what you can see is muscle fasciculations, deep tendon reflexes are increased, and later on it may progress to convulsions and even death. Abdominal plus CNS symptoms. याद रखिएगा, abdominal plus CNS symptoms. Treatment क्या है? Lithium को stop कीजिए, and if the patient's clinical situation is worsening and the levels are too high, go for hemodialysis. Pregnancy and mood stabilizers. It's a common question. So, if a pregnant patient has mania and you are asked the treatment, antipsychotics are the best. Valproate is the worst. You do not want to give valproate. You want to give antipsychotics. Lithium is in between. It can cause abstinence anomaly, but the chances of a patient developing abstinence anomaly is not as high as the chances of patient developing neural tube defects on valproate. Okay? The best is antipsychotic. The worst is valproate. Lithium can be given, but not as good as antipsychotics. याद रहेंगी चीजें तीनों? Psychiatric aspects of pregnancy, एकदम hot question being asked every year. The mistake that you do is you try to remember these days. Do not do that. There are 3 things. Postpartum blues basically will present with mild depressive symptoms. Postpartum depression presents with significant depressive symptoms. And postpartum psychosis presents with psychosis है ना, delusions or hallucinations. ये याद रखना है हमें. If symptoms are milder, we make the diagnosis of postpartum blues. जैसे if the examiner says the patient has tearfulness, sadness, sleep disturbances, some symptoms have been given, you make the diagnosis of postpartum blue. Examiner says that along with these, patient also has anhedonia, patient also has suicidal thoughts, patient has thoughts of harming the baby, patient has guilt, then severe symptoms are there, so you make the diagnosis of postpartum depression. And if the patient has delusions or hallucinations along with all this, then it's postpartum psychosis. Mild symptom, both blues. Significant symptom, depression. Psychotic symptom, postpartum psychosis. याद रहेगा? चलिए, suicide. The suicide rate in India has reached its highest ever numbers. Now the suicide rate in India is 12 per lakh of population. For every 1 lakh people, there are 12 people dying by suicide. Most common method of suicide is hanging. Most common method is hanging, followed by use of poisons. Hanging more than poisons. Yes, Abhishek, the days are not that important. The symptoms are more important. The lower are the levels of 5-HIAA in CSF, the higher is the suicide risk. Lesser the levels of 5-HIAA, more is the suicide risk. What is the most common cause of suicide? The most common cause of suicide is depression. The most common cause of suicide is depression. Almost 80% of the patients who die by suicide, they have depression. What is the biggest risk factor? What is the most important risk factor for a suicide attempt? Who is most likely to attempt suicide in future? Somebody who has attempted suicide in the past. Previous suicide attempt is the biggest risk factor for the future suicide attempt. Then signs of suicidal intent. Say somebody is writing a note or somebody is transferring money to the family members. That hopelessness, we talked about it. Hopelessness increases the risk for suicide. Males have more risk for suicide. So does people more than 45 years of age. And substance abuse also increases the risk of suicide. आपके एग्जाम में क्वेश्चन आया था FMG में copycat suicide is seen in which age group? Adolescents. What is copycat suicide? Say there are a group of adolescents and one member of their group died by suicide, and just to copy him, just to emulate that person, another person from that group dies by suicide. Basically suicide by copying others. Or say there's a famous rock star or movie star, very famous, huge fan following, that person dies by suicide, and just by looking at him somebody else also dies by suicide. That is called as copycat suicide. What is paradoxical suicide? Suicide when symptoms are improving. The patient has depression. The patient was started on antidepressants. When it started to improve, the patient died by suicide. This is called as paradoxical suicide. थैंक यू पिंकी, वी डोंट केयर बेटा, थैंक यू आपके प्यारे शब्दों के लिए. आपको नहीं पढ़ना है तो मत पढ़िए, बाकियों को पढ़ने दीजिए. कहाँ गई मैडम को ब्लॉक करते हैं. तो छोड़ो, उसको टाइम पास करने दो. लेट्स नॉट वेस्ट अवर टाइम. सुसाइड व्हेन सिम्टम्स आर इंप्रूविंग. सो बेसिकली होता क्या है, इनिशियली से इन द बिगिनिंग पेशेंट हैड सुसाइडल थॉट्स बट देयर वाज नो एनर्जी टू एक्ट ऑन दोज थॉट्स. नाउ व्हेन द सिम्टम्स आर इंप्रूविंग देयर इज अ स्मॉल विंडो व्हेन द एनर्जी इज इंप्रूव्ड but patient still has suicidal thoughts. In small window, patient if he dies by suicide, it would be called as paradoxical. Why paradoxical? Because it's a paradox. When symptoms are improving, at that time suicide is happening. That's the paradox. चलिए next topic जल्दी जल्दी करते हैं. We still have got 1 hour left. छोड़ो पढ़ाई करो. ये यूजलेस लोगों को ध्यान नहीं देना इन लोगों पे. Anxiety or fear related disorders. What are the symptoms of anxiety? All of us have felt anxiety, right? All of us have felt anxiety. क्या होता है? There may be tremors, there may be sweating, there may be palpitations, that feeling of nervousness. When you go for your FMG examination, just before entering the exam hall, you'll have some knotting in the stomach, डर लगेगा. All of that is anxiety. All of that is anxiety. Panic disorder. Now students, in FMG examination, this is a very important question. Just remember this phrase. The moment you see feeling of impending doom, your answer is panic attack. Feeling of impending doom, your answer is panic attack, right? What is panic attack? There is so much anxiety. Patient feels so anxious that he feels that there is something severe is about to happen, something serious is about to happen. He may have a heart attack, or may just die, may have a stroke. Patient आके बोलते हैं डॉक्टर साहब, I feel so anxious that I feel that I am about to die. In the examination, you get this feeling of impending doom. Feeling of impending doom. ठीक है? If a patient is having repetitive and unexpected panic attacks, it's called as panic disorder. Repetitive and unexpected panic attacks is panic disorder. ठीक है? तो हमें एग्जाम के लिए क्या याद रखना है? What do we have to remember for the exam? Patient has extreme anxiety symptoms and feeling of impending doom. Arindam is asking how to control panic attack during examination. See, Arindam, I cannot prescribe any medication as such, so of course online, but many people get benefited by using propranolol, right? Beta blockers are usually used for performance anxiety, not exactly panic attack, but for performance anxiety. But the thing is, you should not be using any new medication on the day of the examination. तो याद रखिएगा. Some people take zolpidem before the exam. That is okay. But you should not be taking zolpidem for the first time before the examination. मान लीजिए you sleep a lot, बहुत ज़्यादा नींद आ गई, या next day if you feel that your mind is not working properly, so you don't want to do that the night before the examination. So if you have taken it in the past and you tolerate it well, then it's okay. यार ये कौन? तरुण, तरुण का है? तरुण का है? ठीक है? What is the treatment of panic disorder? You use both medications and psychotherapy. If a patient presents to you in panic attack, what will you do? For immediate relief from panic attack, what will you do? Benzodiazepines. For long-term improvement, what will you do? You will use SSRIs. Immediate improvement, benzodiazepines. Long-term relief, preventing the panic attacks, SSRIs. And you always use, कहाँ पे हो आप? आइए. ये यहाँ पे हमारी कोई मैडम है पिंकी खातून नाम के, इनको ब्लॉक करिए. ना खुद पढ़ रही है ना दूसरों को पढ़ने दे रहे हैं. इफ़ यू आर अ मेडिकल स्टूडेंट पिंकी, ऑल द बेस्ट. पढ़ाई करिए. हमें गाली देने से कुछ नहीं होने वाला. हमें जो करना था लाइफ में हमने कर लिया. आप ही गाली देने से पीछे थोड़ा हो जाएंगे हम. चलिए. Alright, let's talk about certain phobias. एग्जाम में कभी कभी आता है. This was asked in the NEET PG examination. Nyctophobia. What is nyctophobia? Fear of dark. Nyctophobia is fear of dark. What is agoraphobia? Places from which escape is difficult. Patient is afraid of all those places from which escape is difficult. What is claustrophobia? Fear of closed spaces. Ailurophobia, cats. Cynophobia, dogs. Mysophobia, germs. Pyrophobia, fire. Xenophobia, strangers. Thanatophobia, death. Hydrophobia, water. Acrophobia, heights. Rarely question comes, एल्यूरोफोबिया और साइनोफोबिया पे क्वेश्चन डीएनबी एग्जाम में आया था एक बार. निक्टोफोबिया पे देयर वाज अ क्वेश्चन इन नीट पीजी. दे में आस्क यू दिस क्वेश्चन. ठीक है, गॉट इट. नाउ दिस इज इंपॉर्टेंट क्वेश्चन फॉर एफएमजी एग्जाम. आई मीन एवरी एग्जाम. ओसीडी इज इंपॉर्टेंट. अच्छा, अब ओसीडी में क्या होता है? अ थॉट, यूजुअली अ थॉट comes into your mind again and again. The patient gets a thought repeatedly. Repeatedly the thought comes in the mind and causes anxiety. Say I am getting the thought, my hands are unclean. First point, a thought comes to mind again and again. I know that this is my own thought. I am getting a thought, my hands are unclean. I know that this is my own thought. Even I realize that this thought is irrational. Even I know this thought is stupid. I know this thought is senseless. That is why I try to stop this thought. I try to stop this thought, but it doesn't stop. So what do? I go and wash my hands. This repetition of thought is obsession. You going and washing your hands is compulsion. एक और बात याद रखना, obsessions are disorders of, हमने कहा था delusion is a disorder of content of thought. Obsessions are disorders of possession of thought. Obsessions are disorders of possession of thought. ठीक है, obsessions are disorders of possession of thought. Obsessions and compulsions are ego dystonic. So basically what does it mean? Not acceptable to self. When I get those thoughts that my hands are dirty, I don't agree with it. And when I have to go and wash my hands, I don't like it. It's ego dystonic, not acceptable to self. समझ गए? Importantly, what is asked in the exams? What is the treatment of OCD? First question. For the management of OCD, you should give both pharmacotherapy and psychotherapy. Second question. What is the preferred pharmacotherapy in OCD? SSRIs and clomipramine. SSRIs and clomipramine. What is clomipramine? It's a type of TCA. It's a type of TCA. Sometimes you add antipsychotics for augmentation. So you started a patient on a SSRI. Patient that improved by 30%, not more than that. Now you add an antipsychotic to increase the effectiveness of the treatment. And this is also a very important question, students. इसको याद कर लेना, गलती नहीं होनी चाहिए. That the therapy of choice in OCD is ERP, exposure and response prevention. Basically, I was getting thoughts that my hands are unclean. Say you ask me to touch the table. The moment I touch the table, the thoughts that my hands are unclean increase further. This is exposure. And you ask me not to wash hands. This is response prevention. It is done in a proper manner. इतना से simple से नहीं करते, but this is how we treat OCD. Body dysmorphic disorder. The patient thinks that there is something wrong with their external appearance. And they are preoccupied with that thought. Patient may comment, say my nose is too long. Patient may say my nose is too small. Patient may say my lips are too big. Patient may say my lips are too small, right? Basically the patient believes that there is something wrong with the external appearance, and then there are repetitive behaviors. The patient keeps on checking in the mirror, right? Hours are spent looking at the mirror. FMG hot favorite PYQ. Body focused repetitive behavior disorder. In last 3 years, 2 times they have asked a question on trichotillomania, right? Trichobezoar का image based question भी आया था, right? ठीक है ना? कहाँ पे हैं हम लोग? हाँ, so body focus repetitive behavior disorder में क्या होगा? Patient has a repetitive action directed at integument, usually hair or skin. So the important one is trichotillomania. What happens? Patient has an urge to pull the hair out. It tries to stop, fails in that. Pulls the hair out. This is repetitive pulling of hair. After that, he also sometimes eats it, swallows it. Trichophagy. If you have been swallowing hair for quite some time, finally the hair may make a ball. A ball of hair gets formed in the stomach or small intestine. It's called as trichobezoar. This is trichotillomania. आपको इसमें आई थिंक इमेज नहीं लाया मैं, लेकिन आपको दे गेव यू अ इमेज ऑफ अ स्टमक. दे हैड रिसेक्टेड अ स्टमक फुल ऑफ हेयर ऑफ बॉल ऑफ हेयर, and they ask where would you send the patient, and the question was, the answer was psychiatrist. What is excoriation disorder? The patient keeps on picking on the skin, right? They keep on picking on the skin, so all these get injured, and then they put a band-aid on it. That is excoriation disorder, repetitive picking of skin, right? चलिए, trauma and stress related disorder. The first one is PTSD. PTSD follows a serious trauma, a severe trauma, a significantly traumatic event, something which might have led to very severe injury or even death. जैसे कि मान लो somebody gets caught in a war, आप war में हो, bombs गिर रहे हैं, right? There is a natural calamity like flood or earthquake, you are helpless, you can't do anything about it. Or say a very serious accident, say something very serious like rape. So all these things which are very traumatic can lead to PTSD. The mistake that you should not make in these questions is, just because there is history of trauma does not mean the answer is PTSD. You have to look for 3 symptoms. What are the 3 symptoms? First are the intrusive symptoms like flashback. Say 6 months back I was in, say, Hyderabad. I was driving a car and my car was hit by a truck. I had a bad accident. I did not get injured, but it was really scary. Now I have developed PTSD. What are the 3 things that I'm going to happen? First is I'll have flashbacks. 6 months later, I'm sitting in my Delhi office and suddenly I feel as if I am driving a car and a truck is about to hit me. That image of truck hitting my car flashes in front of my eyes. This is flashback. Again and again I get my memories about that accident. They keep on coming. I'm sleeping. In the sleep also the truck is coming and hitting me. I'm getting up. Nightmares, right? So the same thing is intruding again and again. Then I have avoidance. I avoid everything that reminds me of that trauma. For example, I never go to Hyderabad again. For example, I stop driving. I stop teaching. I stop even eating biryani, because eating biryani reminds me of Hyderabad, right? Anything that reminds me of the trauma is avoided by me. And then there are anxiety symptoms also, right? Arousal symptoms also. The duration of symptoms should be at least 1 month to make the diagnosis of PTSD. ठीक है? ये अभी today I am speaking in 1.5x. आप लोग follow कर पा रहे हो ना? You all like increasing the speed ना, तो मैं बोली 1.5x पे रहूँ आज. ठीक है, great. जल्दी करते हैं, we have to finish it. चलो, what is the treatment? अच्छा, 2 बातें ध्यान रखना है एग्जाम में. Please remember 2 things. From psychiatry, if they ask you a question on therapy of choice, and if you do not know the answer, the best guess is CBT. For most of the disorders, CBT is the therapy of choice, right? So again in PTSD also CBT is the therapy of choice. You can also use SSRIs, which are the drugs of choice. Illness, anxiety disorder और hypochondriasis. देखो नाम में ही है, anxiety about illness, anxiety disorder or hypochondriasis. The illness, the name, the diagnosis in the name, the symptoms are in the name. Patient has anxiety about illness. In ICD we call it hypochondriasis. The patient believes, or the patient has a preoccupation that he has a serious illness. And despite investigations coming out to be normal, despite doctors telling him that he is fine, he keeps on going to different doctors. Patient comes to you, patient says, doctor, I have stomach cancer. You say, how do you know? Patient says, doctor, after I eat, some sounds come out of my abdomen. You say they are normal bowel sounds. Patient says, no doctor, do something. You do the CT scan, you do the MRI, you do the barium meal, you do everything. Everything comes out to be normal. You show him the results, you tell him you are totally fine. Patient says, okay. He goes back to home, but then he goes to another doctor, says, I have stomach cancer. Right? Despite investigations being normal, despite reassurances, patient is preoccupied that he has a serious physical illness. This is hypochondriasis. ठीक है? Conversion disorder, important question. In conversion disorder, what is going to happen? The patient is presenting to you with neurological symptoms, but the cause is psychological. So neurological symptoms में क्या हो सकता है? What can happen? Patient may present to you with motor symptoms, weakness in a limb, may present to you with a sensory symptom, or even they may present to you with cognitive symptoms or even seizures. So symptoms are suggestive of neurological disorders, but they do not confirm the anatomical or physiological principles. मतलब patient comes to you, patient says, doctor, I don't have sensations in my right hand. You say, okay, let me test. You test it. What you find is the upper half of the palm has sensations. The lower half of the palm does not have sensations. Now, from your knowledge of anatomy, you know that there is no nerve which supplies the upper part or which supplies only the lower part. You know it's 1.5, 3.5 radial, right? So the symptom is not matching with the anatomical principles that we know of. And there is labile indifference, lack of concern for the symptoms. Lack of concern for symptoms. Patient comes to you, patient says, doctor, I cannot see from my right eye for last 3 days, but doctor, it's okay, it's fine, no big deal, left eye is still working, all good, all is good. You feel as if the patient is not concerned for the symptom. If you have lost vision in one eye, you should be panicking. But this guy is saying that it's okay, doesn't matter. Right? This is INICT question, more common in females. One of the common differential diagnosis for conversion disorder is AIP, acute intermittent porphyria. चलिए सब्सटेंस रिलेटेड बात करते हैं. अल्कोहल, वेरी इंपॉर्टेंट टॉपिक, स्पेशली द विड्रॉल सिम्टम्स एंड द वर्निकेस कोर्सकॉफ साइकोसिस. टॉलरेंस क्या है? व्हाट इज टॉलरेंस? इंक्रीज अमाउंट रिक्वायर्ड फॉर द डिजायर्ड इफेक्ट. Earlier you used to get intoxicated with 2 packs of alcohol. Now you need 5 packs of alcohol. You are very happy that your capacity has increased, but it's not a thing to become happy. You have become tolerant. This is not good. Withdrawal symptoms, the typical symptoms that arise when you stop taking a substance. For example, if you're taking alcohol every day and you suddenly stop, you'll have tremors, coarse tremors. Very important for all the exam, from FMGE to INICT. Alcohol withdrawal symptoms start after 6 to 8 hours of the last drink. Most common is tremors. Most common alcohol withdrawal symptom is tremor, but you may also have nausea, vomiting, hypertension. After 12 to 24 hours, you may have perceptual disturbances like alcoholic hallucinosis. Never asked in the exams. What is asked is, after 24 to 48 hours, you may have alcohol withdrawal seizures. Very important. And they are GTCS, generalized tonic-clonic seizures. Very important. They are also called as cluster seizures. What is the meaning of it? You had one seizure, 20 minutes later you had another seizure, 1 hour later you had another seizure. 3 seizures in 1 hour. They are coming in clusters. And the most important MCQ for your exams, after 48 to 72 hours, delirium tremens. Remember 3 symptoms if you want to diagnose delirium tremens. What are the 3 symptoms? Disturbance of consciousness. The patient may appear confused, agitated. What does it mean? Disturbance of consciousness. Disorientation to time, place, and person. And the third one are any kind of hallucinations may happen, but usually visual hallucinations. So at least 20 questions have been asked from this thing. Patient has been using alcohol for many years, stopped taking alcohol 3 days back. Now he is appearing confused, agitated, not able to identify family members, and says there are insects on the ground. What is the diagnosis? Delirium tremens. Alright. If you have been using alcohol for years, you will have certain neuropsychiatric disorders called as Wernicke-Korsakoff syndrome. Wernicke-Korsakoff syndrome has 2 parts. The first is Wernicke's encephalopathy, which is the acute complication. What is the cause? Deficiency of vitamin B1. Deficiency of thiamine. And how do we remember the symptoms? GOA. global confusion, ophthalmoplegia, and ataxia, most commonly caused by 6 nerve palsy. ठीक है? What is the cause? Vitamin B1 deficiency. What is the treatment? If it is caused by thiamine deficiency, give high dosage of parenteral thiamine. High dosage of parenteral thiamine. When you give high dosage of parenteral thiamine, some patients improve, some patients may progress to Korsakoff syndrome, which is a chronic complication caused again by thiamine deficiency. FMG previous year question, which kind of amnesia is more prominent in Korsakoff syndrome? Answer is anterograde amnesia is more prominent than retrograde amnesia. And there are also confabulations, false stories made to fill the memory gap. Basically, patient is not able to make new memories, patient is forgetting older memories. Patient comes back home from outside in the evening, wife asks, where were you? Patient does not remember. Patient makes a story, I went to that relative's place and then both of us went to park. This false story that he is making is confabulation caused by thiamine deficiency. So treatment is also thiamine, but this time oral thiamine, long-term oral thiamine. Alright, again important topic. What is the treatment of alcohol? See, whenever a patient comes to you with any substance abuse, say alcohol, the first step is detoxification. In detoxification, what you do? You basically take care of withdrawal symptoms. Patient has stopped taking alcohol, now is coming to you with tremors, right? What will you do? You will give benzodiazepines. If the patient has liver damage because of long-term alcohol use, which benzodiazepines will you prefer? Which benzodiazepines will you prefer? Oxazepam and lorazepam, because they are short-acting and also because they are metabolized by glucuronidation, which remains intact even if the liver is damaged. कॉमन क्वेश्चन है, एग्जाम में आएगा. पेशेंट को आप हमेशा थाइमिन देंगे, यू विल गिव थाइमिन टू द पेशेंट. व्हाई? यू डू नॉट वांट द पेशेंट टू गो इनटू वर्निकेस एन्केफेलोपैथी. सो पेशेंट कम्स टू यू विद ट्रेमर्स, व्हाट डू यू गिव? बेंजोडाइजेपिन्स. पेशेंट कम्स टू यू विद सीजर्स, अल्कोहल विथड्रॉल सीजर्स, व्हाट डू यू गिव? बेंजोडाइजेपिन्स. पेशेंट कम्स टू यू इन डिलीरियम ट्रेमens, व्हाट डू यू गिव? बेंजोडाइजेपिन्स. ऑल ऑफ दिस अलोंग विद थायमिन. बेंजोडाइजेपिन्स प्लस थायमिन. ठीक है, याद रहेगा. चाहे डिलीरियम है, चाहे विड्रॉल सीजर है, चाहे नॉर्मल सिम्टम्स हैं, थायमिन प्लस बेंजोडाइजेपिन. मोर इंपॉर्टेंट इज बेंजोडाइजेपिन. ठीक है. लॉन्ग टर्म यू वांट द पेशेंट टू क्विट, you want to decrease the craving for the patient, you want to decrease the craving in the patient. What can you use? Naltrexone and acamprosate. These are more effective. But for FMG examination, somehow they ask question more on disulfiram. What is disulfiram? Disulfiram is an inhibitor of aldehyde dehydrogenase. You start the patient on disulfiram. On the top of it, if patient takes alcohol, he will have a very bad reaction called as disulfiram ethanol reaction. So basically, you want the patient to get scared of alcohol. That's why it's called aversive agent. Patient should be scared of alcohol, that if I take alcohol, I will have a very bad reaction. There will be nausea, vomiting, the BP will fall, right? And you can also send the patient to Alcoholics Anonymous, which is a 12-step self-help group. Naloxone कब देते हैं अगली स्लाइड में देखेंगे. Opioids. Most commonly abused opioid is heroin. Street name is smack. Opioids के बारे में 2 questions are important. First of all तो यही, which is the most commonly abused opioid. Secondly, opioid overdosage can be lethal. If you take a lot of opioids, there may be respiratory depression and death. That is why the question comes, the patient is overdosed on See, the question comes that patient has overdosed on opioids. What is the drug of choice? Intravenous naloxone. Ayush, आगे आपका. Intravenous naloxone is the drug of choice. Intravenous naloxone is the drug of choice. Important question, पक्का आएगा, याद रखना. Cocaine. Cocaine में क्या question आता है? So how does cocaine work? Cocaine blocks the reuptake of dopamine and norepinephrine. If the reuptake of norepinephrine gets blocked, the levels of norepinephrine will increase. It will cause vasoconstriction. Vasoconstriction will cause hypertension. If there is vasoconstriction of coronaries, it will cause MI. How do people take cocaine? They snort it. They make a paper roll and then they snort it. They do like this. When you do like this, what happens? The cocaine is getting absorbed from the nasal mucosa. The vessels of nasal mucosa are getting repeatedly constricted. It is causing ischemia. It may lead to nasal septal perforation. There may also be seizures, right? And age-old MCQ, smoking cocaine can cause jet black pigmentation of tongue. ठीक है? Important MCQ. The intoxication of which substance can cause tactile hallucinations? Answer is cocaine. You take cocaine, you feel as if insects are crawling under the skin. This is called as tactile hallucination, cocaine bugs or magnet phenomena. Patient may present to you with scratches on the forearm. A patient comes to you, you examine the patient, there are scratches on the arm and forearm. What is he likely to be abusing? Cocaine. Because after having cocaine, he is having hallucinations, he is scratching it, and that's why the scratches. ठीक है जी? Tobacco. Most commonly used substance in India is tobacco. Very important MCQ. Varenicline. Very important MCQ. The best treatment for tobacco is now varenicline. How does it work? The usual treatment, more commonly used treatment is nicotine replacement. You say that you are smoking cigarettes. In cigarettes, basically you are addicted to nicotine. But there are other things going inside you, like carbon monoxide and all. So let us give you nicotine, to which you are addicted. You give nicotine in the form of gums. अच्छा, एक चीज होती है, if you are using nicotine gums, you have to have a gap of 15 minutes before, after taking the gums and before it, so that it gets absorbed. When you take nicotine gum, the nicotine gets absorbed through the oral mucosa only. If you drink coffee after it, or if you drink tea after it, the absorption will get deranged, disturbed. So you always have a 15-minute gap where you don't eat or drink anything. More so, the acidic drinks like coffee and tea. But the newer treatment, more effective, is varenicline. How does it work? It's a partial agonist at nicotinic acetyl alpha 4 beta 2 receptors. Alpha 4 beta 2 receptors. So it prevents the reinforcement, it prevents the withdrawal. Pretty effective drug. Alpha 4 beta 2 receptors, partial agonist. And when it was introduced in the market, there was a warning that it can increase suicidal thoughts. Later on, that warning was removed. So varenicline is a very important drug, very likely to be asked in the exams. Mr. Sobons, how much time does it take to get rid of the habit using varenicline? So usually the duration of varenicline is 3 to 6 months. Usually 6 months. Bupropion can also be used for tobacco cessation. Good medication, not as good as varenicline. Difference between delirium and dementia. 3 points we have to remember. You don't have to remember the big tables. 3 points remember. Delirium is always sudden. The patient is fine, no psychiatric illness, nothing, everything is good. Suddenly goes into delirium. Something happened, goes into delirium. Dementia develops very slowly over years or months. The most important symptom of delirium is that disturbance of consciousness is there. In dementia, disturbance of consciousness is never there. Delirium has a fluctuating course. You go and see the patient in the morning, he looks good. In the evening, patient is again confused. Dementia does not fluctuate like that. Dementia gradually increases over a period of time. ठीक है? ये 3 points याद रखेंगे. You will be able to differentiate between delirium and dementia. Almost all questions. Personality disorder. Most important question comes from borderline personality. What is the history? You will be usually given history of a female, young female, more common in females. That's why they usually give history of a female. They say she is very, there are a lot of mood fluctuations. She is very moody. Emotional instability is there. There may be a history of impulsivity, suddenly changing the job, suddenly changing the city, suddenly changing the partner, right? Impulsivity. Unstable relationships and self-injurious behavior. They will say the patient came to your emergency after cutting her wrist or overdosing the pills. And they say she has done it before also. You are asked a diagnosis, you make the mistake that it is a suicide attempt, you make the diagnosis of depression. Don't do that. And if they want you to answer depression, they will give you history of sadness of mood, lack of interest, all of that. Here they will give you a long history. For years, this patient has been having mood fluctuation, never had a serious relationship, unstable relationships were there, multiple episodes of cutting the wrist. What is the diagnosis? The answer is borderline PD. Borderline PD. Okay? What is the therapy of choice for borderline PD? DBT. Dialectical behavioral therapy. DBT. Dialectical. साफ से लिखने की कोशिश की बट फिर से गंदा लिख दिया. एक और बार कोशिश करते हैं. Dialectical behavioral therapy. ऐसे ही लिखा जा रहा है मुझसे यार. तुम पढ़ लोगे तुम, आई एम श्योर. हाँ देखो काफ़ी सपोर्टिव हो तुम लोग, होता है ना. ठीक है. चलिए, इम्पल्स कंट्रोल. लास्ट ईयर आपका FMG का क्वेश्चन, राइट. व्हाट हैपन्स इन इम्पल्स? बेसिकली होता है क्या इम्पल्स कंट्रोल में? यू गेट एन इम्पल्स. से यू आर इन अ मॉल, यू आर इन बिग बाजार. सडनली यू हैव एन इम्पल्स, let me steal this pen. The pen costs 2 rupees. You don't really need that pen. And you also know that you might be caught and it would be very insulting. You have that impulse, let me steal this pen. You try to suppress yourself. No, that's wrong, that's wrong, that's wrong. But impulse keeps on increasing. You are feeling tensed. You are feeling agitated. You can't stop it. You go into a shelf, you pick a pen, you keep in the pocket, you come outside. You feel a bit relaxed and 1 second later, you feel very guilty. कि मैंने क्या कर दिया? What did I do? I again stole, right? This is an impulse. Failure to control an impulse. You get an impulse to do something harmful. You feel increasing tension. You can't stop it. After performing, you feel relaxed, but then guilty. If you are putting things on fire, it's pyromania. If you are stealing, it's kleptomania. If you have episodes of aggression, you have IED. Very important for FMG examination. Excessive sexual desire in males is called satyriasis. Excessive sexual desire in females is called nymphomania. बार बार आता है एग्जाम में. Excessive sexual desire in males is satyriasis. Excessive sexual desire in females is nymphomania. What is aneomania? Shopping. Excessive shopping. You can't control the impulse to shop. You don't have money, the credit card is gone, no money, you see the sale, you just can't stop yourself. सब खरीद के ले आए, पैसे हैं नहीं but खरीद के ले आए. Mutilomania, mutilating the animals. चलो, eating disorders, right? Important is anorexia nervosa. Basically, a thin girl looks at herself in the mirror and what she sees is a fat girl. A thin girl looks at herself in the mirror, what she sees is a fat girl, right? Basically, this is the body image disturbance. Body image क्या होती है? Body image क्या होती है? What is body image? How you perceive your body, right? When you look at the mirror, how do you perceive yourself? Normally, if you are abnormal in weight, you feel that you are normal in weight, right? Sometimes even when you are normal in weight, you feel as if you are very fat. And you start trying to lose weight and then this happens, right? This is anorexia nervosa. So there are 4 things. There is significant restriction of energy intake leading to the weight loss and the BMI goes below 18.5 kilogram per meter square. The lesser the BMI is, the more is the severity of anorexia nervosa. There is disturbance of body image. The patient is very thin but still she is very afraid of gaining weight. And then there are medical signs and symptoms of starvation such as amenorrhea. Post-pubertal female has amenorrhea. There may be development of Lenugo also. Important thing, FMG examination especially, when do you hospitalize the patient? If the patient has developed dehydration, electrolyte imbalances, weight loss is significant, less than 80% of desired weight. Say according to the height of the patient, the weight should have been 50 kg. The weight has gone down to 40 kg. More than 20% drop ho gaya hai, so that the weight is now less than 80% of what it should have been. In that case, you hospitalize the patient. You do behavioral therapy, use certain medications. Question exam mein aata hai, the patient is still not gaining weight. You have hospitalized the patient, you are giving her food, you are increasing the calories gradually, the patient is still not improving. Why? Probably the patient is eating the food, going to bathroom, and she is vomiting it out. So 2 hours के लिए you will monitor after meals. मील्स के बाद एक सिस्टर जी को, नर्स को बोली कि मैम आप इनके साथ बैठ जाइए, सिट अलॉन्ग विथ हर एंड यू लॉक द वॉशरूम बंद कर दो कि वॉशरूम जा ही ना पाए. बुलिमिया नर्वोसा, episodes of binge eating followed by inappropriate ways of stopping weight gain. What are episodes of binge eating? In a small duration, in a short duration, the patient takes a lot of food. In 5 minutes, the patient is eating 5 pastries, 3 pieces of cake, 2 bananas, 5 toffees, 3 biscuits, and finally even the banana peel, जो छिलका था केले का, even that. For that 5 minutes, she just cannot stop herself. Whatever comes in front of her, she eats it. Now she has eaten all this, she ate all of this, now she is feeling guilty. And now something would be done to prevent the weight gain. Most common is purging. How do you purge? You put 2 fingers in the mouth, you activate the gag reflex, you vomit, right? So self-induced vomiting. Some patients also use laxatives, diuretics, or emetics. And some go for hypergymnasia. They eat a lot and then they go for a huge 10-kilometer run. If you are doing this repeatedly, if you are trying to self-induce vomiting repeatedly, the knuckles will get injured against the teeth. So the calluses, the knuckles will develop scars and calluses. Repetitively, HCl is coming in the oral cavity. It will cause erosions of the enamel, causing dental caries. There may be inflammation of the salivary glands. You are losing acid, HCl is going out. You are losing potassium, you are losing chloride. So hypokalemic and hypochloremic alkalosis. Important thing to remember, binge eating and purging can be seen in both anorexia nervosa and bulimia nervosa. It's not that only in bulimia nervosa binge eating and purging happens. It can happen in anorexia also. So how will you differentiate? On the basis of weight. In anorexia, weight is significantly low. In bulimia, weight is usually normal. This is the most important thing. Unlike anorexia nervosa, patients are not secretive, they take treatment. All eating disorders are more common in females. एग्जाम में आ चुका है. And bulimia nervosa is more common than anorexia nervosa. Sleep disorders. Let's talk about narcolepsy. Narcolepsy mein what happens is, basically the REM sleep intrudes into the wakefulness. You are awake, suddenly the REM sleep enters, right? In REM sleep, what we do? In REM sleep, we dream. Now you are awake, suddenly you go into REM sleep, suddenly you are dreaming. It will appear as if you are having hallucinations. The hallucinations that occur while going to sleep are called as hypnagogic hallucinations. The hallucinations that occur while getting up from sleep are called as hypnopompic hallucination. While going to sleep, hypnagogic. Getting up from sleep, hypnopompic. ठीक है, गो से गोइंग याद रखोगे. What else happens in REM sleep? There is loss of muscle tone. Now you are standing, suddenly REM sleep comes, you lose all the muscle tone, you may even fall. I mean, that rarely happens. Usually the muscle tone is lost in only one muscle group, but there is sudden loss of muscle tone called as cataplexy. Sleep attack, irresistible urge to sleep. You are awake and suddenly there is such a strong urge to sleep that whatever you are doing, you will fall asleep. Say I am teaching, I will fall asleep while teaching. Somebody is swimming, while swimming they will fall asleep. They might have, I mean, that may lead to death also. You are driving, you fall asleep, you have an accident. And then there is sleep paralysis. ये 4 symptoms याद रखेंगे. What is the cause of narcolepsy? Deficiency of hypocretin. Basically, this hypocretin keeps you awake. The neurons which create hypocretin, they get damaged by a autoimmune process. What is the drug of choice? Modafinil. And also forced naps. चलिए, sexual disorders. एग्जाम में क्वेश्चन जो आता है आपके PME के ऊपर आता है. What is the normal duration of sexual intercourse? And when do we call it PME? So the definition of PME is if the ejaculation is happening repeatedly in less than 1 minute. Drug of choice for PME is SSRI. Example question. Which behavioral technique is used for the management of PME? It is squeeze technique. Basically, you tell the patient and the partner whenever ejaculation is about to happen, using a thumb and 2 fingers, you squeeze it just below the glands, the coronal ridge of glands. That will delay the process of ejaculation. Second is stop-start technique. When the male feels he is about to ejaculate, stops having sex, takes a break of 20-30 seconds, again starts having sex. Squeeze technique पे MCQ आता है, बार बार आता है, याद रखिएगा. Paraphilias, very important for FMG examination. FMG examiners often ask about paraphilias, right? So sexual arousal and orgasm is achieved by some deviant sexual behavior, right? Voyeurism, what is voyeurism? Peeping Tom. Sexual arousal is achieved by watching others. You watch other people having sexual intercourse or sexual activity. ये पैराफिलिया जब भी मैं पढ़ाता हूँ मुझे लगता है ये YouTube बैन ना कर दे हमारे चैनल को, उसको कुछ और ही लग जाए. So let us not use some, let me use some other words. कोई भरोसा नहीं चैनल बैन हो गया. Exhibitionism is showing. Exhibitionism is showing. You get arousal by showing yourself to others. Frotteurism is rubbing the genitals to an unsuspecting stranger. Sadism by giving pain. Masochism by getting pain. The pain can be physical or it can be verbal also, insulting the partner. Pedophilia with a child. Fetishism using a non-living object. Transvestism by cross-dressing. All of these are paraphilias. Child psychiatry. First of all, let's talk about ADHD. More common in boys. नाम में ही है attention deficit and hyperactivity. The history that you will get is child has inattention, does not complete work, gets distracted, jumps from one task to another. Hyperactivity, roams around in class, खुद भी नहीं पढ़ता, disturbs other students too. Impulsivity, cannot wait. You start asking a question, even before you can complete the question, he answers. Answers before question is complete. What is the drug of choice for ADHD? Methylphenidate. The drug of choice for ADHD is हाँ चलो मिथाइलफेनिडेट. तुम लोग क्यों ट्रोल कर रहे हो बेचारी को? इट्स ओके. कई बार ऐसे बच्चा गुस्सा हो जाते हैं, अपने बच्चे हैं, कोई बात नहीं, चलता है. DOC इज मिथाइलफेनिडेट. ठीक है. अच्छा, ये एग्जाम में आ रहा है भाई. डिसरप्टिव बिहेवियर डिसऑर्डर, डिसरप्टिव बिहेवियर डिसऑर्डर। देखो बच्चों में डिसरप्टिव बिहेवियर डिसऑर्डर है, दो डायग्नोसिस हैं, एक है कंडक्ट डिसऑर्डर, एक है अपोजिशनल डिफाइंड डिसऑर्डर। हमें इसको बहुत सिंपल से याद रखना है। अपोजिशनल डिफाइंड डिसऑर्डर में प्राइमरली डिफायंस है। डिफायंस मतलब मैं बात नहीं मानूंगा, आई विल नॉट लिसन टू यू, नॉट लिसनिंग टू अथॉरिटी फिगर्स, पेरेंट्स की बात नहीं माननी, टीचर्स की बात नहीं माननी, द चाइल्ड डज नॉट लिसन टू पेरेंट्स टीचर्स। लेस सीवियर है ये। सी अ चाइल्ड हु डज नॉट लिसन टू यू, इट्स annoying, irritating, but it's okay. But another level is conduct disorder. Serious symptoms or serious violations. Now this child is not listening to you, that's okay. He's stealing. He's running away from home. When he goes to school, rather than going to school, he goes somewhere else. Right? He bullies other children. He bullies the animals. So all this serious stuff is in conduct disorder. So याद रखना, ODD oppositional defiant disorder, बात नहीं मानता है, does not listen to you. Next level, stealing, lying, aggression, bullying, conduct disorder. Sid is saying I used to do this. Very good, Sid. अब मत करो. Miscellaneous. Electroconvulsive therapy, ECT, right? Basically you give a small amount of direct current which causes convulsions. There are two types, direct ECT, indirect ECT. What is the difference? Indirect ECT we use muscle relaxants plus we give anesthesia. Modified ECT, we do not use muscle relaxant or anesthesia. डायरेक्ट ECT वी यूज, क्या बोल रहा हूं, डायरेक्ट में वी डू नॉट यूज इट, इनडायरेक्ट में वी यूज इट. यूज मसल रिलैक्सेंट प्लस एनेस्थीसिया. लेट मी रिपीट इट. When you give direct ECT, neither you give muscle relaxants nor you give anesthesia. When you give indirect ECT, you give muscle relaxant also and anesthesia also. Which anesthetic agent is the drug of choice for ECTs? Methotrexate. If that is not there in the options, thiopental. Which muscle relaxant is the drug of choice? Succinylcholine. You also give atropine so that the secretions become lesser. ठीक है, ये difference है. Direct ECT has been banned from India. Recently एक एक्ट आया था जिसका नाम था Mental Health Care Act. In that act, direct ECTs have been banned. The most common indication for ECT is depression. With what? Which kind of depression? Which kind of depression? बताओ. Which kind of depression? Very good. Depression with suicide risk. And another thing in which ECT is first line treatment is catatonia. Mental Health Care Act, 2-3 बातें याद रखनी है. एडवांस डायरेक्टिव, एडवांस में डायरेक्टिव देना. टुडे I can write on a piece of paper that later on if I develop a psychiatric illness and if I cannot take decisions for my mental health care, this is the treatment that you can do, this is the treatment that you cannot do. This is my advance directive. Tomorrow if I do develop some psychiatric illness, I lose the capacity to take mental health care decisions, my treating psychiatrist has to follow this advance directive. मैंने जो बोल के लिख के दे दिया आज, 5 साल बाद भी मेरे साइकेट्रिस्ट को उसको फॉलो करना पड़ेगा. वॉट एवर आई रोट डाउन टुडे, माई साइकेट्रिस्ट विल हैव टू फॉलो इट 5 years later. सो दिस इज एडवांस डायरेक्टिव कि भाई मैंने तो पहले से बता दिया है, यही कर सकते हो. आई कैन ऑल्सो नॉमिनेट अ पर्सन दैट इफ आई कैनॉट टेक डिसीजंस फॉर माई सेल्फ, दिस पर्सन विल हेल्प मी टेक डिसीजंस. जैसे मैं कहता हूँ माई वाइफ इज माई नॉमिनेटेड रिप्रेजेंटेटिव, शी विल टेक डिसीजंस फॉर माई सेल्फ और शी विल हेल्प मी टेक डिसीजन. सो शी इज माई नॉमिनेटेड रिप्रेजेंटेटिव. और क्या हुआ है इसमें, डायरेक्ट ECT बैन हो गई है. ECTs have been banned for children, minors. Below 18 आप ECT दे ही नहीं सकते, डायरेक्ट भी नहीं दे सकते, इनडायरेक्ट भी नहीं दे सकते. A good thing that has happened, how doctor will find about directive, your nominated representative or your caregiver is supposed to tell the doctor कि इन्होंने पहले से लिख के रखा हुआ है, ये देखो ये वेबसाइट पे है. Decriminalization of suicide. Decriminalization of suicide. Section 307 IPC. पहले क्या था? If a person attempts to die by suicide and if he survives, police will all put him in the jail. Right? Now we say that, हाँ IPC वैसे भी चला गया है. Now we say that if a person is attempting suicide, we will presume that the person is in a lot of distress. You cannot take any action against that person. है ना? So this is about it, guys. I think we did it in time. So this is about psychiatry. इसको हम भेजेंगे ग्रुप में PDF. We'll send the PDF. अब देखो ऐसा है कि 11th है आज एंड आवर एग्जाम जो है वो 20 को है. अभी हमारे पास 9 दिन बचे हुए हैं. वी स्टिल हैव गॉट 9 days लेफ्ट एंड यू हैव टू कंटिन्यू स्टडिंग till 19th Jan 8 PM. Before that you are not going to stop studying. What happens in the last 8-9 days is extremely important. What you are not going to do is, if you are not feeling good about it, you do not take GTs. No need to take GTs, right? Second thing, what you would definitely not do it, you will not assess your preparation levels. आपको कितना आता है? How much do you know? What is the score that you are going to get? This thought should not be entertained at all. This thought would come in your mind. The moment this thought comes, you have to answer, सर ने बोला है इसके बारे में नहीं सोचने का. I would not think about it. फिर भी ये thought आ रहा है तो use a simple technique, just a flick on the wrist. Thought comes, कैसे होगा, क्या होगा? I will not think about it, stop. I will not think about it, stop. Right? Just use this flick. You cannot afford to waste these last 8-9 days. What will you do in these 8-9 days? Does it matter? It matters a lot. It matters a lot. 50% of our course is factual. It is dependent upon the facts. Whatever facts that you read in the last 7-8 days will remain fresh in your mind. And whatever is fresh in your mind, you are likely to get it correct. Right? So we will not waste even a single moment. I think marathon is ending today or tomorrow. कब खत्म हो रहा है? जब भी खत्म हो रहा है, आज हो रहा है, कल हो रहा है. मैराथन कंप्लीट करिए. Do not read anything new. Complete. Do the PYQs repeatedly. Whatever you have learned in marathon or whatever you had learned in NEET PG classes, जो भी notes हैं, keep on revising them. एक और चीज नहीं करनी है, वो क्या नहीं करनी है? If any friend says पढ़ाई नहीं हो रही, I can't study, do not talk to that person. It's not that the person is lying. There are people who get saturated, but this is a very infectious thought. The moment a friend says मुझसे पढ़ाई नहीं हो रही, तुम्हारी पढ़ाई होनी भी बंद हो जाती है. The moment a person says I am feeling saturated, तुम भी saturated हो जाते हो. Do not talk to that person. Tell him कि भाई नहीं हो रही, कोई बात नहीं, मुझे पढ़ने दो. Right? Let's not talk about it. Do not discuss about it. Right? Try to sleep for at least 6 hours the night before the examination. At the same time, remember, if you cannot sleep for 6 hours, maybe you end up sleeping for 3-4 hours. Even that is okay. I mean, do not do it deliberately. But अगर नींद थोड़ी कम आ जाए, that is okay, because exam के दिन the sympathetic arousal is so much that even if you are a bit sleep deprived, that is okay. Sometimes we get so anxious about not being able to sleep that we cannot sleep at all. तो और anxious नहीं जाना है, it's okay, जो होगा वो ठीक होगा. और and last point, do your absolute best on the day of the exam. What commonly happens is, say your paper is not going good, say you did not do good in the first half an hour, you start losing hope in the middle of the exam. This happens very commonly. Thoughts start coming कि इस बार तो नहीं होने वाला, I would not get selected. That thought brings your energy levels down, and the performance also goes down. Whatever happens in the result, that is not in our hand. But during those couple of hours, you have to give your absolute best. You have to give proper attention. You have to give proper focus. You have to put proper effort on every question. After the examination, we'll see what happens. But during those couple of hours, you have to give your absolute best. ये नहीं सोचना है कि इस बार तो होगा नहीं, क्या ही फायदा है. ठीक है जी, चलिए अब आप लोग सिलेक्ट हो जाइए, पास हो जाइए. आफ्टर दैट वी विल अगेन टॉक ड्यूरिंग द इंटरव्यू. राइट, वी विल टेक योर इंटरव्यू. After you get good marks, 200, 210, 180, 170, get selected, pass the examination, send a WhatsApp message, send a Telegram message, send an Instagram message. We will be waiting. All the best, guys. Do well, study hard. May God bless you all.